Thanks everybody for joining. My name is Jason Friesen. I'm a paramedic by training, and I'm the founder of Trek Medics International. We are a non-governmental organization focused on improving access to emergency care and transport for at-risk and vulnerable populations through mobile phone technologies. And really what we do is exactly the name of this presentation, which is how to build and coordinate emergency response networks in austere environments. Just to give a little bit of background, Trek Medics works in about 20 different countries with different types of emergency response organizations, whether it's ambulance services, fire departments, disaster response, search and rescue, or more, we'll call them community-focused response organizations that are dealing with problems like domestic violence or gender-based violence, as well as mental health crises and even opioid overdoses. But what I'm going to give you a little presentation today is about our work helping these different organizations set up their systems, coordinate access, and scale. And what you're looking at here is actually a picture from one of our original programs that we started back in 2014 from an organization called Rescate Ambar in Dominican Republic. And the way that we help these organizations primarily is through a text message based emergency dispatching platform we've created called Beacon. And I'm not going to talk specifically about Beacon today so much, more generally about the function of dispatching. But this is definitely a tool that we have built specifically because of these problems. And we'll get more into that. So just to give you a quick overview of what we're going to be doing today, a couple goals are to review the universal emergency response workflow. And that's something we haven't trademarked that term yet, but that's the term we use to describe how to find out who needs help and how to get them help. And as you'll see, it's a pretty universal way to go about things, no matter what your emergency response is. Then we're going to talk about the 4 components that go into these emergency response systems. Once you have that in mind, then we'll talk about the 6 questions needed to establish a baseline. So let's say that your organization is responding to a post-earthquake setting and you are looking to set up an emergency response network to coordinate patient intake to your field hospital or to existing facilities. You need to figure out what the lay of the land is, so to speak. And that's what we're going to go through with these 6 questions. And then finally, we're going to discuss how the 3 of those can all be used to really help you get up and going, get a system launched, and then be able to manage it as you manage patients and possibly even hand it over upon your deployment or your demobilization. So those are the goals for this session. But to give you a little background about how this all started, I'm going to talk about the Haiti earthquake here. So in 2010, I responded with an organization called Giving Children Hope. They are out of Orange County, California. And they had a couple orphanages in Haiti that they needed to send supplies to, a whole lot of medical, I think something like 25 pallets. And you can see here that one of the orphanages was connected to a church, and that church was turned into an open air clinic. And we were just getting started here. But one of the things that was apparent was, on the one hand, while we did have, you can see here on the left, some Haitian American nurses and doctors, we also had a lot of folks who didn't speak Creole and were not of any Haitian background. And so as a result, we had to rely on locals to help us treat patients. You can see here on the left that this gentleman in the jersey was a translator for the nurse who didn't speak Creole. At the same time, lining this clinic were a whole lot of people who were just watching and they wanted to help. And in fact, I didn't get a picture of it, but I remember standing and looking at all the people who were watching us, and there was a group of about 15 Boy Scouts, all decked out in their uniforms, you know, pressed, clean, perfectly dressed uniforms. And they were so eager to help, but because we were running a clinical operation and they didn't have any clinical background, there wasn't a lot that we could do to get them involved. But I remember thinking, you know, as a paramedic, that we had all these patients coming into the clinic from who knows where. They're coming on the back of motorcycles. They were coming in the back of pickup trucks, or they were even walking to the clinic. And I was looking at these Boy Scouts and I was thinking, wow, if there was a way that we could organize them and send them out into the communities, I bet you they could help these people get to the clinic a whole lot more efficiently. And in fact, maybe divert some to other facilities or other clinics that were going on based on capacity. So that was kind of just something that was going through my head, like, wow, we've got all of this human capital here, all of this local knowledge, but we don't really have a very good way to put it to use. And I was like, well, thankfully, we don't have to be doing any transports out of here because we wouldn't know where we're going if we did. Lo and behold, shortly after that, a young pediatric patient who was septic and in respiratory failure, verging on a respiratory arrest, was brought to the clinic. And it was apparent that this baby was very sick and this baby needed one thing, needed oxygen. And at our clinic, we did not have oxygen. So lo and behold, they turned to the paramedic and a nurse and they said, we need you to get this baby to a hospital with oxygen. We don't know where they are, but we have transportation for you. And you need to get going fast because this baby's very sick. And so that's what we did. And we went outside and here was our transportation. This was the ambulance. So we piled into the front of the ambulance. And for the next 3 hours, it took us about 5 different vehicles going to 4 or 5 different facilities to finally get the patient to the one place that had an abundant store of oxygen. And that was the USNS Comfort. You know, we traveled about 5 miles over 3 hours in just gridlock traffic, plus all of the rubble. And what we were doing was essentially an interfacility transfer, but we were making it up as we go along. And I couldn't help but think, wow, if we had some local, you know, knowledge here and we had this in a coordinated way, we could probably have set up some kind of a system to have done this so much more efficiently. So fast forward a year, then the Haiti cholera outbreak happens. And now I'm back in Haiti and I'm living there. I was at the time the country director for an organization called Project Hope. And I remember we were in a meeting with the Ministry of Health and all of the international partners. And we were talking about the cholera outbreak. And the thing that came up, I remember specifically, one of the ministers said that 95% of all cholera fatalities were happening outside of the hospital. And so they began to discuss, well, how can we solve this problem? And they took a little survey among all the NGOs and health partners about how many ambulances they had. And then they quickly realized that the ambulances that were available, nobody was going to give them up and put them into like a communal pool, so to speak. And they decided that the solution to this problem of having 95% of fatalities happen outside of the hospital was that they needed to build more cholera treatment centers. And so this for me was difficult to hear because in my mind, the reason that 95% of the patients were dying outside of the hospital probably wasn't because they didn't have enough cholera treatment centers, but more because people couldn't get to the centers that existed. And as you can see, this was actually one of the chairs that they were using to get people out of the hills down to the clinics. And so this kind of, you know, dissonance, I guess you could call it, of the problem is people are dying outside of the hospital. How do we prevent that from happening? And the clinical solution was to build more clinics. While our, you know, from a paramedic's perspective, from an EMS, someone who works outside of the clinic and is involved in delivering emergency care, I felt like the answer was actually different. Instead of going out and building more clinics, maybe there would be a better way to coordinate response and transport so that you could get sick people to the hospital more efficiently. You know, cholera is actually very easy to treat. You just need to get them fluids by and large, and you can turn people around very quickly. So one view was we need to build more clinics, and another view was we actually just need to improve the transportation to get people to the clinics that they have. And so this is kind of something that has always stuck out to me, and is really the premise for Trek Medics in many regards. The point is, a lot of times response teams have a tendency to misplace the focus of their operations. And how do they do that? By emphasizing features over functionality. In this case, the features were the transport destinations, whereas what we were thinking about was more the functionality of the entire system. And this is what I'm going to talk about pretty much for the rest of the presentation here, is the whole idea of features and functionality. And so I think we kind of set people up to not think this way to begin with, because we in the United States, in Canada, in English-speaking countries with formal response services, we call them emergency medical services. But the reality is that there's not a lot of whole medical going on until late in the play, right? It's more like an emergency logistics system that has a focus on emergency medicine. And you can see here that you can split these services up into two components. There's the demand side, where people who need help, and then there's the supply side with people who can help. And this here is actually, as I mentioned before, what we call the universal emergency response workflow. And again, that's not trademarked yet, but that is something that we've come up with as a name. So how does this workflow work? Well, there are 5 components in it. There are 5 steps in it. First is access, which is a way for people to call help. Once they've called help, then you have a dispatcher of some sort, whether they're a formal dispatcher or just someone who answers the phone. They innately take care of 3 roles. First, they interrogate the person who's calling to find out what the need is. Then they do some type of triage, which is to say they determine which resources are available, what this person needs to get help, and how do we finally get them to those resources, right? How do we trigger the whole response system so that these resources can get to the people who need it? So once you've gone through call handling, then there's response. And this is when the resources, or the responders for that matter, get engaged. And they do at a minimum 3 things. They are alerted, they confirm when they're on their way, and they confirm when they are on scene, right? So that's, so far, as I mentioned before, going back to this slide, so far we haven't talked about anything medical, right? Everything we've been talking about has been coordination and logistics. Now, finally, in step 4, when they get on scene, the intervention, now they can provide medical care. So here we are in 5 steps. It's not until they get to the 4th step that we're now talking about medical care. And so the intervention is how the whole supply system provides help. And then there's finally an outcome, which we're calling, just for the sake of simplicity, transport. And this, when it's talking about emergency medical service, is a way to seek definitive care. So these are the 5 steps of the response workflow. And when I say universal, what I mean by that is it doesn't really matter what the emergency is. It could be a road traffic incident. It could be a pregnant woman. It could be a cholera patient. It could be somebody stranded on a roof. The workflow is the same. What happens is the different parts are the little features that we call them. And so here you have an example of what I mean by feature versus functionality. A feature is, as we define it, a tool needed to complete a task, right? So access is how to call for help. Call handling is how to figure out what's needed. The response is how to get there. The intervention is what you do on scene, and transport is kind of the outcome, right? These are all features of a system, but the real purpose of this system, or the functionality, is how these features all work together to attain a desired outcome. And generally speaking, the outcome is to stabilize the patient and prevent the emergency from getting worse, right? It's not necessarily cure, it's not necessarily providing any type of specific care, but the goal of an emergency response system is to stop the problem from getting worse. So I'm going to go through a couple examples here of how this emergency response workflow works in different contexts. So let's talk about a basic pre-hospital trauma care system. This is kind of the bread and butter of an ambulance service, right? So in this case, access is that somebody who is in a motor vehicle collision needs help. On the call handling side, call handling can get pretty intricate, right? People can do some pretty sophisticated call intake processes and triage and interrogation and ask all sorts of questions. But for the sake of conversation, let's boil it down to its most essential function, which is to find out what is the location of the patient. If all your call handling consists of is finding out where the patient is located, going to be successful. So access is for somebody who's in a motor vehicle collision. Then a response in this case is an ambulance. When they get on scene, they stabilize the patient. That's their intervention. You know, stop the bleeding, plug holes, you know, stabilize legs or broken limbs, and then transport to a trauma center. So that, again, is kind of your bread and butter trauma response system. Well, if we changed it to hurricane setting now, right? Let's say we are in Louisiana after a major hurricane hits, and now there's flooding everywhere. Well, in this case, who needs access is a stranded victim, someone who's on top of their house and the floodwaters are rising. They connect with someone who can figure out where they are. And then the response, instead of an ambulance, is an outboard motor. The intervention is rescue, getting them off the house and into the boat, and they may transport them to refuge or just some type of dry land, right? So the same components in the same places, we're just kind of plugging in different features. Then if we take it to an internally displaced persons camp, right? So in this case, let's say it's a victim of gender-based violence and they're the ones who need help. The call handler finds out the location and they send a crisis counselor. The crisis counselor, when they get on scene, can intervene in some way to separate that victim from the perpetrator. So they're essentially providing advocacy. And then if there is transport, and that's what that little asterisk means, if there's transport, it would be to a woman's shelter, or it would be to some kind of safe house, or, you know, wherever it is, or the transport may be taking the perpetrator away to jail. So here you have, again, the same components, but it's a different context. And finally, if there's let's say we're in a conflict zone, right, where there's a lot of traumatic things happening and you have people who are having a mental health crisis. Well, the person in this case who's accessing help is someone who's having a crisis. The dispatcher finds out their location. They again send a crisis counselor. They provide some type of counseling, and maybe they transport them to a safe place. But the desired outcome in this case is just, I guess, for lack of a better term, Stacy's, right? Trying to get them back to a baseline where they can manage the situation better and begin to work on self-care. So again, these are 4 different situations where we're really going through the same workflow. It's just that the features are changing a little bit in each situation. So let's say that you're interested in building one of these yourselves, right? You have people who need help and you have people who can provide help. And you want to set up a way to enable this workflow so it can be used over and over and over again. And you're like, well, how do we build this? Well, there's actually a really straightforward way to organize your thoughts and to organize the resources so that you can build these systems. And the 4 components are right here in front of you. They are responders, so people who can help, and also dispatchers would go in there too. Then there's transport, which is a means to get to and from the incident location. So how do you get responders to the patient? And then if you need to get the patient somewhere else, how do you get them there? Those are, it's important to remember, are 2 different types of transport. You may only need a motorcycle to get responders to the scene, but you will need a different vehicle appropriate for transporting that patient if you're going to take them anywhere. The 3rd component is communications, which is a means to coordinate responders and transport and communicate with people who need help. And then finally, and most importantly, is management. And this is just how do you ensure that the service is delivered and that it could do it continually. I have put together at the very end of this for a deeper dive into these components. I'm not going to get into these for the sake of time, but they are here. And if we're sharing these presentations afterwards, you can look at these. But we're going to keep it simple for right now, which is the 4 core components of responders, transport, communications, and management. So now what I'd like to do is really quickly just go through different ways that we have used the workflow and these components to build systems in different austere environments. Oh, sorry. Don't want to get there yet. Forgive me. So you've got the 4 core components. You know what the workflow is. And let's say that you would now arrive on scene in a post-disaster setting, and it is your job to set this up, right? So you arrive on scene and it's like, okay, you're in charge of making this happen and you want to figure out where to get started. Well, you need to establish a baseline, right? So there's 6 questions that you need to ask to establish this baseline. And if you ask these 6 questions, you're going to see that things start falling into place. You're going to see what resources you have, in what components, and you're going to see how these fit into your theoretical workflow. And then you're going to be able to fill gaps. So the 6 questions that you need to ask are, what types of emergencies are happening? If you are somebody who is specifically focused on, let's say, gender-based violence, then the point is to figure out how often is this happening and where is it happening? If, on the other hand, you're like a medical organization in general and you're going to take whatever comes your way, then it's a good idea to figure out what are the common emergencies that are happening. So once you've got an idea of that, then you want to find out, how does the public call for help, right? Whatever way they are using to currently call for help is what you should tap into. This could be a formal number like 911, or it could be something less formal like the NGO headquarters or the hospital, or it could be something even less formal like WhatsApp chat groups, right? That word just spreads that people are around and trusted people in the community are called. And that's how, emergencies are reported. As many different ways as there are to call for help, if you can find them out, then that's going to help you plug into the system. And it'll actually give you a foot up when you're trying to coordinate this and hopefully eventually consolidate these numbers. So then once you find out how the public is calling for help, then you want to find out who is responding, right? Is it a local ambulance service, a fire department? Maybe there are other NGOs, or maybe it's something like a local Boy Scouts, right? Or it could be just a women's group. A lot of times what we call in the US emergent groups, where it's just concerned citizens banding together. You see this after the hurricanes all the time. It's people getting their outboard motors and they go and help because they know the fire department has been flooded and the ambulance services have been flooded and everybody's basically on their own. So finding out who is responding, if they are doing any type of triage, how are they being alerted? These are just things to figure out to get a lay of the land. And again, it doesn't have to be sophisticated. If there's any type of response going on at all, you want to tap into that because they're going to have a wealth of knowledge for you to work from. Then you want to find out what interventions are these responders providing. If there are responders doing anything, it's good to know what they're doing so you can find out, is this something that you can join, or is it something to avoid because of duplication of efforts? And also if you're starting to talk to delivering healthcare itself, especially in the field, there may be some concerns with local laws and regulations. And that's, again, going back to what the locals could help you with if there are formal response groups. So I remember in Vietnam, there was a problem where they were trying to train laypersons to take blood pressures. And lo and behold, turns out it's illegal for non-physicians to be taking blood pressures. So that was, the kind of things, just a small little detail, but something that you would definitely want to find out about if you're working with local organizations. After you find out what interventions they can perform, you want to find out how do they transport. This is important because transport vehicles, especially if you're talking about ambulances, come at a premium. And so you want to find out what's going on out there so you can, again, avoid duplication of efforts, or you can find out the best way to leverage those resources. And then finally, if they are transporting, where do they transport to? Is it a formal clinical facility or is it a tent? You know, whatever it is, in the end, if you're doing any type of transport or you need to get people to higher levels of care, it's important to know where you're going. In the case that I gave with that baby, we didn't know where we were going when we first got into that truck. We just knew that we had to find a hospital. And so we used local knowledge to find out where the nearest hospital was. We got to that hospital, they didn't have oxygen, so it was on to the next one. If you can have this stuff mapped out before you get in the vehicle, things are going to go a lot more smoothly. So if you arrive in a post-disaster setting or any type of, you know, austere environment and you want to get started, these are the 6 questions you need to ask to get started. But once you have all of that, those 6 questions, then you can start to plug and play, so to speak. You've got your 6 questions here. Now you know your 4 components and how existing capacity falls into those. And now you can see where your capacity is going to fill gaps or, you know, form the infrastructure itself. Once you've determined the 4 core components and where you fit into those, then you're going to want to take a look at what the current response workflow is using the 5 steps of that workflow we talked about. And finally, you'll be able to figure out how will your organization best serve. Are you going to be doing this in collaboration or do you need to be doing this independently? For example, if the Red Cross is already on scene and they're responding in a certain community, then you may figure out you don't need to respond in that community. They've got it under control. You can go to the community next door. Or, you know, they are responding in a community, but they are drastically understaffed and they could really use your help. So you're going to get involved with them there and in a collaborative way. Again, so filling gaps, or are you establishing the infrastructure itself? So basically, if you need to set up a response network, here's a very 1-page card to help you do it. Now I'd like to just talk about how we've done this ourselves. And I'm not going to take too much time here to go through these, but I'm going to give 4 quick use cases about how we took those 6 questions, we took our core components, and we looked at the existing workflow and how we came up with a solution. So in this case, this was the Dominican Republic, 2014 and 2015. And just to skip ahead to the workflow, what they were doing at the time was there were 2 ways that people called for help. They either called the local volunteer ambulance station, where whoever was at the station answered the call on their landline, or they took personal calls to their mobile phones, or oftentimes they found out about emergencies through WhatsApp. And what they did was they had local resources, meaning they had a couple ambulances and motorcycles, and that resulted in either short or long response times, depending on where the emergency was. The intervention was what we call basic life support, or also known as first aid. And they did transport to hospitals if their ambulances were in service. Other than calling the local station, what they did was they would call friends and family. And when I say variable call handling, it basically means the person who answered the phone was like, I'm going to find private transport and get to you. And that was the end of the call handling. So when they're doing private transport, more often than not, they have very short response times because they're flagging down the first car that they see, or they're asking the neighbor, or, you know, whoever's on scene. At best, they were doing first aid, and the transport again was provided by private and self-transport. So this is the way things worked when we started. And this was through a grant from USAID. And what we came up with was a way to leverage that existing resources, that existing workflow, and incorporate it with local fire departments and volunteer services. And what we turned into was what we call direct dispatching. And so what happened was whoever was called, right? Somebody was in an injured, they called any number of different people in these organizations. Whoever they called were able to use either a simple desktop or a mobile phone to dispatch the responders on motorcycles and on foot, as well as an ambulance who could get to the patient and provide care. And so this is what we set up, a very simple way that we took all of the different people that were getting called in an emergency, and we effectively made them mobile dispatchers, right? And I mean mobile in the sense that they were on the move. They could have been in their personal vehicle, at home, at the station. And they were also mobile in that they were using mobile devices or a computer to do the dispatching. And so these were some of the organizations we were working with. And the interesting thing was that oftentimes Northern Dominican Republic is hit by hurricanes. And so when hurricane season came, how did they change their system? They just turned up the volume, right? They would bring in different types of vehicles. They would recruit other responders who could just help clear paths, you know, that weren't medically trained, but they could just other people, you know, other helping hands on scene. And so they loaded more people into the system so that when the volume went up, they had the capacity. And then when the waters receded and, you know, they were back to normal, then those volunteers went home and they took the big vehicles out of service and went back to regular motorcycles and ambulances and private cars. And so this system you can see here is actually, we've been working with them consistently for 7 years now. And they do a very high volume of calls every month and in different areas of the country. So another example is in Puerto Rico. After Hurricane Maria in 2017, we got involved. And the interesting thing about Puerto Rico is that they have a huge number of very well-trained EMTs and firefighters. And all over the island, you'll meet people who are very well trained. The problem is they don't have the infrastructure, right? They don't have the organization. There is a state EMS system, but it is in the rural areas quite anemic. So the way things were happening before and during Maria was that there were basically 3 ways that people were getting help. They would call state 911. But that often resulted in long response times because state ambulances are few and far between. Now they could do advanced life support or basic life support, but again, it was long response times. So especially in rural areas, if the ambulance is going to be 45 minutes, an hour, hour and a half away, that's a lot of time for things to get worse. The other way that people called for help was they called the local fire station or the local emergency management station. And there were dispatchers there who could corral state, or if in some cases the local community had it, like a volunteer organization had their own ambulance, they could call them. The 911 system doesn't call the volunteer ambulance, but the local station would. They too could do advanced life support or basic life support, and if they had an ambulance, they could transport. But sometimes it would just be that the responders would go on scene, stabilize the patient, and wait for the ambulance to come, hoping it would come. But more often than not, what happened was that they were calling friends and family, and they were getting private transport over here as soon as possible so that maybe somebody who had first aid could be on scene and provide transport via private vehicle. Sorry for the background noise here. So this is the way things were going before and during Hurricane Maria. And then when we got involved very shortly after, we worked with all of these different ways that they were dispatching, and we found a way to kind of homogenize them or at least plug into them. So in some cases, if somebody called 911, 911 would dispatch their ambulance, and some 911 dispatchers would use our software to advise local responders who could very often get on scene before the state ambulance did. Another way is that the volunteer organizations would listen to the 911 scanner. So when they heard a call go out in their neighborhood or in their region, they would use our software to alert their responders as well. So they were kind of piggybacking on the 911 system using scanners. But then the most common way was direct dispatching, where somebody would call the local volunteer group, or somebody, they would call a person, a specific individual in that volunteer group, who could then call 911 to make sure that an ambulance was en route, but then they would use our software to dispatch their local responders, who more often than not get on scene before the state ambulance does. So whatever they were doing, we found ways to plug in and not disrupt it. We didn't say, no, 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 we're going to start from scratch and do it our way. We said, what are you doing and how can we strengthen that? And since then, we've been working in Puerto Rico, and we've now got over 250 responders in the north and the west and the southern coasts. I think it's something like, you can see here are about 8 of the volunteer organizations that we're working with. There are a couple others as well, but it's really saying to the local volunteer organizations, what are you doing and how can we strengthen this? And so since then, Puerto Rico has been hit by several more hurricanes and even a couple earthquakes, and the system just keeps running because they've already been doing this. We've just given them tools to help them coordinate a bit better. Here's something that's going on right now, another program. This was completely different, right? So we've been talking about like trauma and, kind of standard emergency response networks, but then there's something in, different types of people need different help. And sometimes organizations are only prepared to provide certain types of help. And that's what happened here in Haiti. What they wanted to do was this NGO out of University of Florida called MotoMeds. They wanted to do something very specific. As many of you are aware, children get sick at night. And that's often when clinics and, pediatricians are unavailable, right? They're closed for the day and the child gets sick at night with a pretty standard illness. But then if it left untreated by the morning, it becomes an acute emergency. And so what MotoMeds wanted to do was they wanted to make sure that these kids at night could get basic care so that simple cough or cold or, whatever it was, diarrhea, didn't turn into an acute emergency. And so they needed a way to set up a system basically from scratch. And they came to us and said, how do we do this? And so we did our assessment. They wanted to do pediatric illnesses at night. There was no way to call for help after hours, meaning after 6 p.m. and before 5 a.m. There were no responders doing anything at the time, and therefore there was no interventions being performed. All transport, if it existed, was 100% self-transport, and they would transport to local clinics if they were open, or they would wait until the morning to go. Or if it was really acute emergency, then they would venture out at night and get to a hospital, which was typically far away. So we said, all right, what are the core components available right now? And they said, we have trained nurses and motorcycle taxi drivers. For transport, we have motorcycles. We have no communication set up, and we're the NGO that's going to manage this, right? And then there was no existing workflow, so we had to do this from scratch. So what we did was we did 2 things. First, we set up a simple pediatric health hotline in a place called Cressier. And the way it worked was that between the hours of 6 p.m. and 5 a.m., somebody would call the hotline, which was a Digicel number. That Digicel number forwarded it to Twilio Flex, which is a cloud-based call center platform we use sometimes, not always, but sometimes for high call volume centers. And then Twilio Flex was also integrated with our software Beacon, where the dispatcher would either send a nurse and motorcycle driver with medications to the patient's home, or they would send the motorcycle taxi driver with medications only to make a delivery. So this was going on for 2 years. And then in August, the earthquake hit in Lake Hai in southwestern Haiti. And we got together and we said, it sounds like up to 70% of healthcare clinics in southern Haiti have been damaged or destroyed in the earthquake. There are tens of thousands of refugees, internally displaced persons, like popping up in little makeshift camps. We know for a fact that children are going to be getting sick at night, and there's no way to get them care until the morning. So those pretty standard illnesses are going to become acute emergencies, further putting a bigger burden on the local healthcare systems. Maybe we can do something about that to relieve the burden on the local healthcare system. So what we did was we worked with Motomeds to set up, and they very much, you know, this is their program, and they really spearheaded this and got things done quickly. Really impressed by how efficiently they work. But what we did was we just said, all right, we're going to start the same program in Lekai. So we need nurses and we need motorcycle taxi drivers, and we need a little bit of promotion. So now people in Lekai can call the same phone number, which relays that call to Twilio Flex, where dispatchers answer it. And the dispatchers are all in Glacier. And if they find out that the patient is in Glacier, then they dispatch the motorcycle taxi drivers and or nurses in Glacier. Or if they're in Lekai, they dispatch the motorcycle taxi drivers and or nurses in Lekai. And so it's really a bifurcation of the same exact workflow. We just found people in a new location. Again, going back to the original model, we had access, we have call handling. What we needed was more response, and we needed to make sure that they could provide interventions. So we needed motorcycle taxi drivers, we needed nurses, and we needed medications and supplies. And so that's been going on. And I can tell you since the first week, they've been doing about 4 times the volume that the Glacier program does. Shortly after we launched too, the missionaries were kidnapped in Haiti. You know, the 17 missionaries were kidnapped in Haiti, and that was kind of a wake-up call to us. And we were very concerned, should this continue? But because the program is being run entirely by Haitians, we felt like there wasn't as much a threat. We are still playing it by ear, of course, but it's been running ever since, despite all of the problems that have been going on. So finally, real quickly, we got a contract with the World Bank to set up a call center in Malawi, and it was kind of simple, same as Haiti. There wasn't really anything going on. They didn't have any formal call system. They had trained nurse and first aiders. They had 12 ambulances, though most people were relying on private transport. They got a 118 short code that people could use to call for help. The problem was there were no radio networks at all in Malawi outside of Lilongwe and Blantyre, the 2 big cities. So it had to be entirely digital, you know, cloud-based, and it was being managed by the Ministry of Health. But in terms of existing workflow, there was nothing going on. So we had to set this up from scratch. So what we did was basically very similar to what we did in Haiti. So the access was they called 118. 118 forwarded the calls to MTL, one of the telecom providers, who forwarded the call to Twilio Flex, where dispatchers in a single call center answered the phone. And then they simply dispatched using our platform, depending on what district it was in. So if it was District 1, they alerted responders and they sent an ambulance, right? And this was a really interesting thing where they only had limited ambulances, and it was along a 250-mile stretch of highway. So the ambulances may have had to have traveled up to an hour. That's a long time for an injured person to be waiting, especially when there are panicked bystanders potentially making problems worse. So they set it up so that they had 500 community responders along this stretch of highway in addition to the ambulance. So you could get community responders on scene quickly, and then the ambulances would show up when they got there. This was a pilot program, and I could tell you on the call intake side, very quickly they got up to about 7,000 to 8,000 calls a month. They certainly weren't dispatching for every one of those calls, because a lot of them were people trying to find out if this was for real. It was also a bunch of kids doing prank nuisance calls, but they certainly got this set up and we're getting a very high call volume. So that was gratifying for us. So those are 4 ways that we did this in austere environments. Again, the 4 core components, I'm not going to go through this, but these slides are here, and reach out to me and I can send them to you, or I think there will be a recording. But the message of this is really, one way or another, people are going to get to the hospital, right? When they're sick and they don't know what to do, then they load up and they make their way to the hospital. This was a pregnant woman who was pregnant with twins. This was in Haiti. She was pregnant with twins. She delivered one. The other one didn't come out. They knew they needed to get her to the hospital. So they tore the door off of the front of the house, put a mattress on it, laid her on it, gave her a little umbrella, and put that door on their head, and took her down the mountain. And you can actually see the gentleman is holding a phone and he's text messaging. I'm assuming he's text messaging for help. But you know, this is the kind of thing where it's like, the door is not, it doesn't look pretty, but it's pretty innovative. And where these people were living, that was smart. That was the only way they had to get her down the mountain. The problem is that now they're on a paved road and there were cars driving right by. That's where you can say, look, we can coordinate a system to make sure that they're not carrying her a mile down the road on a paved road as cars are driving by. Here's wheelbarrows from cholera, the same thing. If that's what you need to get out of the woods, to get out of the mountain, to get out of the inaccessible areas, that's perfectly fine. But once you are on a paved road, there should be a very simple way to set up a system to get a vehicle to you. People all over the world are using very innovative ways in low accessible settings. I think as NGOs and as people who understand how these systems are coordinated, it's incumbent upon us to set up ways for them to formalize this transport once they get out of the woods, so to speak. So yeah, I'd like to just say really quickly a thanks to our sponsors. Cisco, Twilio, PagerDuty, and USAID have been absolutely instrumental in helping us get this platform up and running. We started this back in 2013 as, oh, we just need a way to send simple text messages. And it has gone so far beyond that, beyond anything we imagined. And we're so grateful to them, as well as the World Bank New Relic, ICRC, the US Coast Guard, and Impact Northwest for really helping us with implementation and seeing how this stuff works on the ground. If I may really quickly, if you're interested in what we're doing, please reach out to me. I'm more than happy to talk, but we are actually looking for 2 specific types of support from the community, if it's possible. One is our MotoMeds Healthline. If you are interested in finding out if you're operating in Haiti and in the area and would like to get involved in our hotline and either expand the scope or expand the region, assuming it's safe for you, then this hotline is scalable. And we are more than willing to bring other partners into it, or to do their own thing, or to help us with ours. And then finally, if you're operating in East Africa, we have started a new collaboration with community emergency response organizations in East Africa. It's very similar to Puerto Rico, where you have a lot of volunteer organizations who are doing good things, but because they're small, volunteer, community-based, they don't get a lot of exposure. They aren't taken seriously by the government. And we're just working on a collaboration with a bunch of them to get them a bigger seat at the table and help them with standards and really demonstrating that community-based organizations are legitimate and can do a lot of good. And if they can get more resources and support from the quote unquote establishment, they can really get a lot done. So here's my contact information if you'd like to reach out. We have a few minutes left, so I guess I'd like to open this up and see if anybody has any questions. And thank you again to NetHope for this opportunity. We're really excited to be new members and so grateful for the opportunity to present here. Does anybody have any questions?